Now we go to the next session. We have another very good speaker, speaker from Jodhpur itself. We have Dr. Ravindra Shukla, and for that we will be having our chairperson as Dr. R.K. Khemsara, and I would like Dr. Anil Agarwal to please be a moderator. So Dr. Khemsara, please take over.
Thank you very much, sir. The next speaker is Dr. Ravindra Shukla. He is MBBS, MD, DM, Endocrinology and Metabolism. He is presently working as an assistant professor, Department of Endocrinology at AIIMS, Jodhpur. He has various publications in national and international journals. He is a very good speaker and advisor and investigator of many clinical trials. His topic is evidence to experience, choosing the right DPP4 inhibitors. Over to Dr. Ravindra Shukla.
I think I can start it quickly. This presentation would be on choosing the right gliptins. As we know that gliptins have become cornerstone of diabetes management. Next slide, please. Yeah. Next slide, please. Yeah. So the long-term durable glycemic control is difficult goal. Now we know that most of the patients they have an A1C of about 7, and we set up for an A1C of 7 to 8. Because of availability of gliptins, it is not possible to target, and we should be targeting an A1C of less than 7. Next slide. Now, the progressive decline in beta function is one of the key challenges. And as we discussed in the previous talk also, with COVID infection also, chances of beta cell failures are high. Next slide, please. So this diagram what it shows that beta cell it declines over the years, beta cell function. The red line in the left hand side is shows that, and the A1C it is fluctuating, but there is consistent decline in beta cell function, and if we use sulfonylureas, this decline could be accentuated. And there's recurrent failure. Most of the patients they will have the failure. Next slide, please. Now, therapies which show intensive long-term glycemic control and they protect and recovery of beta cell function. So these are the therapies which are needed, and the most promising strategy for successful diabetes treatment prevention would be this. So, needless to say that gliptins become a first, line drug when we think of these aims. Next slide, please. Now, DB4 inhibitor is I would not say it's a novel therapy, but it addresses the complexity in the management of diabetes mellitus. Next slide, please. Now, because of the incretin effect, some of the beta cell function could be preserved. So, euglycemia is a goal, but if you preserve the beta cell function as well, that is achievable on the long term. And they also have potential to address this glycemic control. What are the advantages of DP4 inhibitors? All the guidelines they keep DP4 inhibitors as a cornerstone of management, and also it is associated with the CV neutrality. It is not harmful. For example, sulfonylureas they have been shown to have a more hypoglycemia and thereby more death due to CV outcome. Both the advance and the VADT trial because the predominant medicines used in those trials were sulfonylureas, which DP4 will be the right choice as an add-on. Next slide, please. Next slide. Yeah, so the right choice of DP4 inhibitors would depend on the efficacy, safety, glycemic variability, and the inhibition of DP4 activity. Next slide, please. So different DP4 inhibitors are different in the inhibition. Next slide. Yeah. So in the next slide, we'll see what is the percentage of inhibition of different DP4 inhibitors. Next slide. These are the 4 DP4 inhibitors which are being used in the doses, which is given 50 mgBD, 100 mgBD, 5 mgBD, and 20 mgBD. And you see that it is highest to the Vildagliptin activity even after dilution, which means that OD 50 mg which we were using is also highly effective. On the contrary, sometimes we use sitagliptin in 50 mg BD. We do not use OD. So this shows that vildagliptin has got good activity inhibition. Next slide, please. Next slide, yeah. Now, what is efficacy? Next slide, please. Ability to achieve target A1C is how many percent of the patients would achieve. So this has been found from this trial that almost about 60% they achieve the target A1C in vildagliptin. In sitagliptin and saxagliptin also it is more or less the same. Now the LPGA responses, fasting blood glucose response is better with vildagliptin. This is because the DB4 inhibition is sustained. It's given in BD doses. So in the fasting time, vildagliptin is acting with sitagliptin. It has got around just less than 24 hours of action, maybe 20 hours. Now the glycemic variability is a very important thing, and we can target it with the help of DB4 inhibition. Next slide, please. Next slide, please. Yeah, now this is the most commonly used metric for evaluating glycemic variability. So we've shown that the MAGE is less than 30 in this, and the greater reduction in MAGE is associated with vildagliptin. Next slide, please. Next slide. Now, what is the safety? Most important thing which we think of is hypoglycemia and weight gain when we think of safety. So next slide. Now this next slide. It shows the incidence of hypoglycemia with different inhibitors. Next slide. So it shows that what is the effect of body weight. So if you see most of the time the vildagliptin 100 mg it's given, it has highest probability reducing body weight. Next slide, please. Now, risk of hospitalization, saxagliptin was shown to have, there was some issues with that as well as sitagliptin. Now, these are the reversible. So, with vildagliptin, risk of hospitalization is less, although there are no CV trials, but it is considered as the safest in terms of CV. Next slide, please. So, this shows the incidence of first HHF and the risk of HHF with DB4 inhibitor. So, vildagliptin does better than saxagliptin. It also is better than sitagliptin in those patients, in those who are at risk of heart failure. Next slide. Now, what is the effect of LVEF? Now, mostly the SGLT2 inhibitors are used in these patients. So, vildagliptin is neutral; it doesn't cause harm. That's what this slide shows. Next slide, please. Next slide, please. Now, the FDA guidance of the CV it requires CV to be proved, which vildagliptin has not. No trial has been done in the US. That's why it's not approved. But it has got a long data of CV safety from the European regulators, and the risk ratio has been favorable on observational studies. So these are the studies, written in the time when they were done, from 2010 to 17. And this shows that the inhibition was better in vildagliptin, there was better FPG and HbA1c reduction. Next slide, please. Next slide. So this is a preferred add-on to the anti-diabetic therapy, as well as it is a preferred gliptin to start in diabetes. This ends the talk. I think we can take questions.
Sir, every gliptins are same, almost little bit difference, except gliptin.
Yeah.
Pardon? But,
yes.
But except for DP4 inhibition, there are inhibition of DP4 8 and 9. So what is the effect of vildagliptin on these enzymes?
Okay. Yeah, as compared to sitagliptin and saxagliptin, 8 and 9 and other, the specificity of vildagliptin is less. That's why arthralgias are more in sitagliptin, but I don't think it has got any effect. All the gliptins that we are seeing, and inhibition of what we call the parallel effect. They are not much of use. We have seen that there's no effect on the immunity. That is the first thing. That there should be increased susceptibility to infections. There should be increased susceptibility to rheumatological manifestations, which has not been shown in any of the gliptins. So it's more of its lab phenomenon. Even the prolonged DP4 inhibition, I do not agree with it. All the gliptins clinically they have that thing. Despite lab evidence of sitagliptin leading to beta cell regeneration and vildagliptin leading to prolonged inhibition of DP4, I do not agree with that.
So it is safer to give in liver disease also vildagliptin in comparison to other gliptins.
50 mg linagliptin can be given without closing eyes. It can be given 50 mg of vildagliptin. I think that is there. Can give it. Depend on what is the compensation. If it's a compensated liver cirrhosis, the 50 mg can still be tried. Decompensated, no role for any of the anti-diabetic medication, only insulin. If it is compensated cirrhosis with some preserved, like there is no coagulopathy, then all the gliptins can be given in full dose. So that's depending on.
No
thank you, doctor.
Okay. Thank you, sir.
Thank you, sir. Thank you very much. It has been wonderful hearing you, and you have made things so clear. I think most of the questions have already been answered in your topic in the discussion we just had.